when the world has got you down. And
Alzheimer's sucks. It's an equal opportunity disease that chips away at everything we hold dear. And to date, there's no cure. So until there is, we continue to fight with the most powerful tool in our arsenal, love. This is Love Conquers Alz, a real and really positive podcast that takes a deep dive into everything Alzheimer's, the good, the bad, and everything in between. And now, here are your hosts, Susie Singer-Carter and me, Don Peirce.
Hello, I'm Susie Singer-Carter, and this is Love Conquers Alz. And today is actually a very special day because not only do I have two amazing, outstanding, and adorable guests today, and I do mean adorable, but I also have an equally outstanding and adorable co-host with me today. And her name is Rosanne Corcoran. And like me, Rosanne cared for her mother, Rose, for over a 12-year span, starting as she puts it, a stealth caregiver to a full-time caregiver to an in-home sandwich caregiver for her mother in her final 6 years. And after finding herself a part of this growing caregiving community like me and in need of both support and critical information, she has conducted an exhaustive research into caregiving strategies for aging parents. And to assist the community and share information and provide support, Rosanne started a regional daughterhood circle, which is incredible. Look it up and will be in the show notes. It's a wonderful organization in the Philadelphia suburbs in 2019. And then in November of that year, she created Daughterhood, the podcast. You can also visit Rosanne on her website, heyro.com, for caregiver information, inspiration, and a little company. I want to emphasize a little because I've become very possessive of this woman as my new BFF, and you're about to see why. So please welcome Rosanne Corcoran.
Thank you, Susie. Susie, so much fun. I've looked forward to this all week, Susie. To be on the same in the same show with you is just too exciting for me. So thank you for the opportunity.
Well, I love, this is the best part of being, one of the best parts of being part of this community is meeting really, really fabulous, fun, loving, heart-centered people like Rosanne, who brings a whole, her podcast is amazing. And she brings a whole other perspective and voice to what we talk about all the time. And that's what's so great about this community, because everybody has a voice and no two situations are alike. So you try to find voices that resonate with you. And maybe a lot of them do, and maybe just one, but honestly, this lady is fantastic. And I have leaned on her so much that I can't believe that she still likes me. So she has been my rock during this whole thing with my mom and the hospice situation. And actually which is why I wanted her on this particular episode, because we're going to be talking about this nursing home crisis, which is all part of a system that we're all up against. And so she has her experience, I have my experience, and then our two amazing guests have their experience, right?
Absolutely.
Yeah. So
very excited to talk to them.
Yeah. And Rosanne lost her mom about a year ago. So her journey is from that perspective, over her shoulder, but still well in it, still well totally in the grief and the, looking back in the assessment of the whole process, right?
Yes, absolutely. And I cared for her at home, but I still have experience and know a lot of people who have gone down the same road that you're in, Susie, in that trying to navigate the entire system. And anyway, if you're at home or if you're at a community, it's still the same system.
Yeah.
There's definitely differences, but overall, as we will find out with Rick and John, it's a system, and
we're up.
It's hard.
It's hard.
It's hard.
Yeah, whether you have it at home or not, because that system is still that system. So
you're still a commodity.
Yeah. Right. Yeah. Okay. Well, I think we should just jump into it because I want to just get into it.
Absolutely.
And this is a part 2, which is very exciting for us. And this is my first part 2, I believe, in episode 51. If you haven't listened to it, please do. We dropped it just earlier in January this year. And Dawn, my loving co-host, who is busy golfing today, and well-deserved, and I spoke with Rick Mountcastle, who is the Assistant Attorney General for the Commonwealth of Virginia and a retired federal prosecutor, and in my humble opinion, a bona fide hero. And I mean that
Totally.
And Rick, along with his partner, Randy Ramsire, led the investigation and prosecution of Purdue Pharma, which was falsely marketing OxyContin, which my family was also a victim of. My brother was addicted to it, and it's a horrific drug. This case was the center of DOPESICK, which was a riveting Hulu miniseries of the same name, in which Rick is beautifully, beautifully portrayed by Peter Sarsgaard. And I literally gasped out loud in episode 9 when I found out that they announced that their next case is going to be going after Abbott Labs, right?
Yes.
Who are falsely marketing Depakote, another drug that my family's been a victim to. It's a drug that's supposed to treat epilepsy, but instead they were targeting nursing homes to treat agitation, which is associated with dementia and Alzheimer's, which my mom was exhibiting and was falsely diagnosed when she was going to a doctor's appointment as some kind of mental breakdown. And they locked her up into, a mental hold for 72 hours, which turned out to be 7 days. It just makes your heart feel a little bit lighter that there's people out there that actually care.
Absolutely. It gives you hope in that there is someone who has integrity and honesty and wants to stand up for the right thing. And it gives me hope.
It gives everybody hope
that there are still people out there.
Yeah.
Yes.
And Danny Strong, who wrote and directed it, he did such a great job of putting a face to this crisis. Faces, actually, not a face, a lot of faces. And that's what we're trying to do with Love Conquers Alz and Daughterhood, the podcast. So we're so grateful to have Rick Mountcastle back again to continue this important conversation that we started before, along with one of his lead investigators, John Peirce. But let me just brag on John a little bit. So from 1973 to 2005, John Peirce was employed as a special agent, a criminal investigator with the Criminal Investigation Division of the IRS in Western Virginia, Eastern Tennessee, and Western North Carolina. He investigated numerous cases of tax fraud, as well as financial crimes associated with illegal activities, including drug trafficking, gambling, manufacturing of illegal liquor, cigarette smuggling, and investment fraud. In 2007, John was hired as a criminal investigator by the Virginia Office of the Attorney General, Medicaid Fraud Control Unit. In 2013, he was promoted to Investigative Supervisor. He assisted in several healthcare fraud investigations of providers, including physicians, pharmaceutical companies, nursing homes, and pain clinics. Many of these investigations were conducted in conjunction with the U.S. Attorney's Office before he retired in 2021. Not only did they find that Abbott Labs was not the only pharma targeting nursing homes, they witnessed firsthand the negative consequences of understaffing, which is unfortunately too common in too many nursing homes, where people are viewed as commodities and compassion as a liability. And since COVID, we've seen the resident to staff member ratio exponentially increase out of control, resulting in a huge uptick in the cases of nursing home neglect and abuse. Now, obviously, there's amazing places. My mom has been at them, and they're very competent and caring and compassionate. But that's also not to say that these other situations don't occur and occur too often. So without further ado, please, please, please help me welcome the Honorable Attorney General Rick Mountcastle and his ace investigator, John Peirce. Hey, guys.
Susie. Hey, Roseanne.
Thank you for being here. And I know you have to do your disclaimer.
Yes, and I am currently an Assistant Attorney General with the Virginia Attorney General's Office. I'm actually going to be leaving that position sometime in June. It's time for me to maybe go off to pasture. But I needed to say this disclaimer because I'm still working for him, and that is that any of my statements or comments during this podcast are my personal views or opinions and are not in any way related to my position with the Office of the Attorney General. So that's the legal disclaimer.
So back off, everybody.
We're just having a
Yeah,
conversation.
we're just
that's all.
chatting. Talk amongst yourselves.
Exactly.
John, thank you for coming. I know I don't know if you've done a podcast before, but I don't think so. I think we're your first. Is that correct?
I think that's correct. I'm glad to be here today. Appreciate the opportunity, but yeah, this is my first experience with this.
Well, we're delighted to have you, and we're delighted to meet such a lovely person with such a gigantic heart. And I love your accent. And
Some things you just gotta live with.
you gotta live with it. Yeah. I just want to just jump in. Roseanne, do you want to start talking? Yeah.
Sure. I mean, I think that we all, as people, as caregivers, as people that are advocates, we feel like the healthcare system is here to help us in some way, shape, or form. We take our parents, our spouses, our children, whoever, and we go into the healthcare system and think that we're going to work together to solve this problem or to solve whatever issue that we have. And as both of you have pointed out, it's more that it's a system than an actual cooperation between us. It's not about patient-centered care. It's kind of moved into spreadsheet care, unfortunately. And I don't know if you can talk about that a little bit as how it's a system now instead of what we were hoping for.
One thing that Susie said was that she was lamenting that in dealing with healthcare providers with regard to her mother's situation, she's had to become the bad person or the bad guy. That is, the person who is raising a ruckus, questioning the healthcare providers, maybe even having to raise her voice, be somebody that she does not want to be and is not naturally, but in order to make sure her mother is properly cared for, she's got to turn into this other person who might be viewed as mean and nasty when on the people on the receiving end. Let me just comment about that and the need to do that. She's having to do that, and many of the people listening to your podcast who are caregivers end up having to do that because they are fighting not that individual healthcare provider, not that nurse, not that doctor, but basically a system that is in place that is not designed to provide care on an individualized basis. It is designed to provide care on a mass basis. And your particular loved one who you are there to care for is not viewed on an individual basis. And so all of those people that you're having to deal with are part of this system. They have pressures coming from the system. For example, nurses and CNAs and LPNs that are in direct care in a skilled nursing facility, also, or what we call a nursing home, have pressures to get things done with a limited amount of staff. And so they're responding to that pressure as part of this system that is designed to basically turn your loved one into just a spreadsheet number. Okay. And so when you find yourself, and I say this to all the listeners, turning into someone that you wouldn't necessarily like because you have to be loud and maybe aggressive and sometimes even mean, recognize that you're having to do that because of the system, not because of the oftentimes understaffed and individually beleaguered healthcare provider.
That's a really important point, because I know that, and even though I know that, and I've said it to the staff, and I've said, I know you're understaffed and just bear with me. I'm trying the best to be, to help you, help me. And still, when emotions run high, you just think, come on, am I the only one that sees this? And is anyone going to say anything? And it's hard because my heart breaks for them. It really does. But then you're in survival in a way. So you're stuck between a rock and a hard place. So you said that just right,
Yeah, you have to do it. You have to do what you have to do.
Yeah.
And John, don't know if you have any.
Well, the reality is you have to do this because I think what we're dealing with in the system is you have, by the time the resource gets down to the level of the caregiver, that resource goes through a lot of parameters that are set by sections higher up. And what you have by the time the resource gets down to the application level in the nursing home, the care being given to the patient. Those caregivers at that first line level are basically, in most cases, not given enough resource to meet the needs that's there. Through no fault, largely, and a lot of the time, it's no fault of their own. So because the resource has been limited along the way, now you're at the position where it's being delivered and the resource is just not there. It's insufficient. And a lot of the reason behind that is the money angle, the profit angle. Decisions are made higher up to maximize profits. And that impacts directly on the amount of resource care that is delivered to the people down at the ground level. So like Rick said, we see a lot of the problem begins higher up. It's not all occurring down here on the ground level. So that is part of the problem in the system.
It is, and it's confusing because it can be at the bottom level, at that level. It can be on the one, and we can't. So it's hard because you can't dismiss one for the other. Although most of it is coming from the top down, and I have seen that. I witnessed it just recently in terms of just this poor woman, this poor young nurse being thrown out on her own to take care of my mom on the floor at night and making a huge mistake. And basically she was so frazzled. It was her first time alone on the floor. And she said, I don't know what I'm doing. And when I brought it up to her supervisors and the organization, it was like, it's a training problem. Your mom's okay. We got it under control. Thank you for pointing it out.
So, we used to be able to rely on physicians and other healthcare providers because they have the knowledge, right? They know how to treat patients. We think what's in the best interest of your loved one.
Mm-hmm.
But I think that the profit motive, the money aspect of it, especially now, has changed things quite a bit. All right. So, for example, if you have a loved one that is living in a skilled nursing facility, and there's a change in medicine, okay, and because there's some issue that's come up with them, they're given a specific medicine. And if you, as the loved one, the person who's looking out for your loved one, go and ask, why are they getting this particular medicine? Like in your example, Susie, why have you prescribed Depakote? The answer you're probably going to get is the answer from the system, which is the doctor has determined that this is the best medicine for this problem for your loved one.
Mm-hmm.
And you as a layperson would tend to, I think, go along with that because, hey, the doctor knows best. Well, that I don't think is how you can approach these things nowadays because of the system in place. One of the things that is out there in almost every nursing home is that they have what's called a drug formulary. And so they have a certain list of drugs that they prescribe for, that they say, this is our formulary. These drugs are what we're going to give for whatever particular ailments there are that those drugs are assigned to. And that's it, okay? And the reason that many of those facilities have those drugs on their formulary is because the pharmaceutical company and or the in-house pharmacy, and I used to be the two big ones were Omnicare and Pharmerica. I don't know if there are more nowadays. And or there's a rebate system where if they put the nursing home puts that drug on the formulary, the pharmaceutical company and the pharmacy are going to exchange money, and there's going to be a rebate, and the nursing home may get a rebate.
Right.
So what you have to be aware of when dealing with healthcare providers in a skilled nursing situation who are prescribing drugs is you have to be aware that that prescription or that drug might be getting dispensed to your loved one, not because it's in their best interest, but because it's on the formulary and it is financially profitable for that nursing home to use that drug off of its formulary because they're getting a rebate from a pharmaceutical company or a pharmacy. What us as normal, lay people who don't have medical training, we're thinking, oh, the doctor's going to make, or that nursing home's going to make that decision based on what's best for my loved one. Not necessarily the case. Now, I'm not going to say that they're going to do it in all situations, but you have to understand that part of the system is this financial pressure to get rebates from the pharmaceutical chain, from the pharmaceutical company and or the pharmacy to prescribe certain drugs to your loved one, whether or not it's best for them.
Right.
That's when we talk about the system. That's what we're talking about. There's this financial system in place that steers how healthcare is provided.
Can you go through the roles of that system? Yeah, because you were sharing that with us in our pre-interview. And well, you think, how is Susie Singer Carter going to go up against this? And, I'm now looking over my shoulder everywhere I go now, because after watching DOPESICK, I'm like, is that person following me?
Yeah, so let's start at the top. We've got the FDA, Food and Drug Administration, that we all believe this is the government agency that's making sure that the drugs that are approved to be prescribed are safe and effective, that they're watchdogging how the pharmaceutical companies are marketing those drugs. They're going to make sure that they market it in a correct way. And they don't necessarily do everything that they're portrayed to be able to do. Okay. So there's pressure even in DOPESICK, there's pressure on individuals in the FDA who are employed to review and approve drugs to make sure that they are safe and effective and that their labeling is proper before they are disseminated to patients. They have pressure to cater to the pharmaceutical companies because they want to go work for them at some point, okay? And just like in the Purdue case, Curtis Wright approved OxyContin as safe and effective, and he approved some pretty, I'm going to call it lethal language in the package insert that enabled the company to say, hey, the FDA agrees with us that it is that OxyContin is less addictive and less abusable than any other opioid. And Curtis Wright, after he approved that, shortly thereafter went to work for Purdue. And there's nothing illegal about that, okay? That is the system that allows this sort of cozying up between the FDA's individuals who work there, cozying up to the drug companies because they want to go work and make a lot more money than they're getting paid at the FDA. And that's part of the system in place that is financially driven and not patient driven. The pharmaceutical companies are out there and they're trying to make as much money as they can off of their drugs, and they're looking for ways to cut corners, operate in the gray area, as they did in the Abbott case, where they began marketing Depakote for something that was not approved and not determined to be safe and effective, that is for agitation in elderly dementia patients confined to nursing homes. They did that. The FDA is out there, and Abbott was able to do this illegal marketing for at least 8 and maybe more years, okay, before our office, before John and Harold caught up to them. All right.
Yeah.
So where's the FDA for 8 to 10 years? Well, not only do they have this financial pressure on some of the individuals to cozy up to the pharmaceutical companies, but they're also understaffed in terms of how they have been reviewing the marketing by drug companies. I mean, they have an office of about 50 or 60 employees who basically are responsible for looking at more than 30,000 marketing pieces per year. An impossible task. So
Wow.
they can't.
Oh my goodness.
Yeah. How is that allowed? Who thought that was a good idea?
Well, that's, Congress, which is part of the system, are the ones that appropriate money for the FDA. So it's not necessarily who thought it was a good idea. It's part of the system.
Right.
Okay.
Right.
So, and of course, the insurance companies are out there, and they're going to pay. They're going to reimburse for what, for certain categories of drugs. And doctors in nursing homes, and I'm not going to say that this is 100%, but many of the ones that I've looked at are doctors who are doing the nursing home rounds as a side job, as an extra job. That's not their main job. They've got an office where they're seeing patients that are paying them a lot of money. Nursing home patients, by and large, are, there are some that are self-pay. At some point, their money gets used up and they become Medicaid patients, and Medicaid doesn't pay doctors that well. Okay?
Right.
So this is sort of a side gig for them. So they're not necessarily paying a lot of attention to your loved one who is confined to a skilled nursing facility. In fact, many of them probably don't see your loved one more than once or twice a year. And they're either a nurse or a nurse practitioner is actually the person that is seeing your loved one. Okay.
He's saying the truth, you guys. I mean, I'm going through it right now.
Absolutely.
It's exactly how
Absolutely.
Rick is saying it.
And that's part of the system because it's part of the financial system because it's not financially profitable for the physician, the doctor, to spend a lot of time
Right.
with your loved one in the nursing home, right?
Mm-hmm.
And of course, we've already talked about how the drug companies pay rebates to get their drugs on the formulary. The nursing home wants to make sure that they prescribe the drugs on the formulary because it's cheaper for them. They're getting rebated and incentivized by the drug companies and the pharmacies that serve the nursing home. So all of these financial pressures, which include the government, are working together to form a system that you as a loved one who is trying to look after your mom or your grandmom or your grandpa in a nursing home, that's the system you're having to fight. And so you have to be very much of a mean person, a questioning person, a skeptical person, and not take the doctor thinks this is the best thing.
Right.
You might,
Right.
might want to ask, are you prescribing this because it's on your formulary? Is that why you're prescribing this drug instead of this other drug, which my, mother was on
Right.
previously that worked well?
Right. When my mom went into hospice, suddenly she was taken off a couple drugs. And I said, without asking me, and I said, why are you doing that? I mean, I thought that's going to keep her comfortable. I'm wondering if it was because they weren't on the formulary, because I had to fight to keep her on the blood thinner. Yeah.
And we don't know, but you have to question that. You have
Yeah.
to make sure you're factoring that fact into and process, using that to process what they're telling you. Okay.
Right.
And maybe you have to ask that point of question. Well, is drug A the one you're giving to her now? Is that on the formulary? And what about drug B, the one that you didn't give, that you stopped? Is that on your formulary or not?
Right.
Let's hear what the truth is about that.
Right. And can they go outside of the formulary, or it's just advantageous, or they have to stick to the formulary?
Corporate policy probably tells them you have to stick to the formulary.
Gotcha.
The
Right.
actual what you can and can't do is they can go outside the formulary, but it's going to cost more.
Them.
It's going to cost them.
Them more. It's going to cut into the bottom line.
It makes so much
And
sense.
so,
Makes so much sense.
and so corporate managers are probably telling them you cannot go outside the formulary, and then they've got to go get permission up the line, I think, to do that. and go, and so again, part of the system is they go through those folks that you're talking to that have to go and ask, well, you know, Susie has come and she wants her mother on drug B, which is on a formulary. They have to go through, you know, basically people don't like conflict. Well, now they're in a conflict with their boss and
Right.
the boss's boss.
Right.
They want to, right? Everybody wants to take the path of least resistance. That's
Exactly.
human nature. And you're forcing them into some kind of conflict, which they don't like.
I get it. And I don't like it either. I don't like it. And you're so right. I'm just going to keep validating everything you guys say so I can put a face on it and just say, you know, my mom has been in desperate need of a wound doctor, a specialist to come in. And they kept, when she got back to the place that she's at, and they said, yes, we're going to do that. And then it took 3 weeks to get a nurse practitioner who they told me was better than the doctor. And only once. And now my mom is back in the hospital because of this gigantic, horrible thing on her back.
Oh, God.
And
That's awful.
it's awful. And so, yeah. And, you know, so you cannot, unfortunately, you trust anything that's said to you. If you smell something's wrong, believe it. Right, John?
Exactly.
I see you shaking your head. Yeah.
You have to understand that it gets back a little bit to what I was talking about a little earlier, is a limited resource in a nursing home. So they may take the resource away from your mother and put it over here. They move that around, unfortunately, because there's not enough resource to take care of all the needs. So they move that around.
Right.
And they do that to create the easiest scenario for the nursing home. So if they get a Susie that comes in and now becomes somewhat disruptive, my mom's not getting this. And you know, I've got a problem with it. And I'm going to be back tomorrow if you don't fix this. So you become the bad person, like you said, you become the bad person too. Now you get the attention, and prompts them to move the resource back to your mother. So that's kind of what you're faced with. You already know this. But again, it's the profit motive is reducing the amount of resources getting down to the ground, is because we're looking to maximize profit, not maximize quality of service. So the amount of services getting down has been minimized because the money has been taken off in another place in the chain. It's like Rick has said, that's the way the system works.
Quality of service, thus quality of life.
Exactly.
Right?
Same.
It's amazing though, because, okay, so it's the system and the pharmaceutical company, the FDA, the insurance company, the skilled nursing. Okay, so it's this circle. Well, how much money that they're making, that the resources aren't being, you know, pushed to the people, which is who they're supposed to be serving, but yet they're compiling this massive profit. So when is it enough? I mean, they keep running to make this profit. That's great. Well, is $1 million profit enough? Is $4 million profit enough? In the meantime, the people that you're serving are suffering every day. So how do those scales get back into balance? Because they're horribly out of balance right now. What can be done to get them back into balance?
That's a huge question.
Oh boy.
That's a huge question.
I know. But you know, I mean, really.
Well, it comes down to how rich
horrible.
can people be. Like, nobody needs billions of dollars. It's dangerous to have that much money, I think, but that's a whole nother topic.
But is that it? It's, and I don't want to say it's as simple as it's profit, but is that what it really, all of this, the way it's set up, is that really the bottom line here? It's just profit.
If you're asking me, I'd say the answer is yes. The way that nursing homes have been run has changed, has evolved over the years. You know, it went from being sort of a local community place where the community was involved in it. Their loved ones were in this nursing home. People from the community worked in the nursing home, and people from the community made financial decisions for that nursing home. So there was a lot more it was more personal, right? The CEO of that nursing home you know, their kids went to school with the kids of someone who has a loved one there. So it's all that has now changed to where these nursing homes are now being they're owned and operated by investors. Okay, one or more investors who don't live in the community, who, you know, put together a group of nursing homes as an investment. They maybe get some other investors in who have no relationship to that community. And now it just becomes a balance shoot. And and more of a corporate type of entity, and the nursing home is part of that corporate group of nursing homes. And the people that are now making the decisions, they're not looking at quality of care. That's not one of the factors. They don't get briefed on quality care at their monthly meetings. They're getting briefed on profit, return on investment, and if it's a corporation, what's the share price? And the briefing also has a discussion on it, and how can we increase each one of those things? What do we need to do to increase them? But never on any kind of those agendas, my opinion, will you find item number 4, how do we improve care?
Right.
That's not going to be on the agenda.
And would you say that they're also motivated, because I'm feeling this, by, you know, that they make a lot of decisions based on their fear of liability. So they take the path of least resistance in terms of, let's do everything not to be liable for, you know, any kind of misconduct. I've heard from nurses saying, I can't do that. I don't want to get fired. We're not allowed to do that because we could be liable.
You might have your folks who are the employees, who are the hands-on people that are worried about getting fired. But I think in our experience, the hires up in terms of worried about liability, John, what do you think that the CEOs, the owners of a nursing home, how much do you think they worry about liability or being caught doing something wrong?
Well, what we've seen is they establish policies that possibly are being carried out, but what we've seen in the investigations we've had is people at the upper corporate levels tend to feel assured in the levels of insulation that they have, that they are not walking the halls every day, that they are not taking the complaints from the ground level, that they're, you know, states away. They're making decisions possibly, okay, we're going to put money into this, we're going to put money into this, we're not going to put money into this. They transmit that down to the people on the ground who are making the decisions that could be facing liability issues. Whereas the corporate people feel like, well, you know, we didn't carry that out. You know, we're here making these decisions. So what we've seen is typically they at the higher levels, they tend to feel fairly well insulated. They don't, like Rick says, they don't seem to worry a lot about that kind of liability.
Really? So like, even if they're caught of misconduct or like wrongful death or anything like that, they're not driven by that, or they're insulated, is what you're saying. Did I say something wrong?
You did.
Did I go right there? Is that bad?
If you have an incident of abuse or an incident of lack of care that takes place at the local level on the part of a nurse or a CNA, tracing the responsibility for that back through 3-4 layers of corporate management to an executive vice president or a vice president who may be sitting 3-4 states away, who has not been in that facility, maybe never.
Right.
So establishing that connection sufficiently to seek any kind of criminal charge is a pretty high burden. And that's, of course, what we did. That's what our job was. And it can be done, but it can be a difficult task.
Gotcha. For the average, not a sleuth ace investigator and a fabulous assistant attorney general.
Well, yeah, well, I don't know about that, but just let me say, and maybe this is a topic for another podcast, because John is alluding to a case we did after the Abbott case that involved a nursing home and trying to hold the corporate CEO owner who is in Florida liable. It was very difficult, and it may be something we can talk about in another podcast because it's a whole story unto itself. But the other part of going back to the theme of the system, okay, I will also say this, my personal opinion is that the Department of Justice, who I worked for 32 years, and I enjoyed every minute of that job as a federal prosecutor, but the Department of Justice is part of that system as well, okay? And as came out in the Purdue case, when the folks on the ground wanted to prosecute, executives at Purdue for serious felonies, the Department of Justice, the system went into motion. They prevented us from doing that. And I believe that the Department of Justice also prevents not only that case, but many other cases where there are laws in place, federal laws in place, a federal law in place, where you could hold executives personally accountable criminally for the conduct of their corporation that violates federal law. And that Department of Justice, for some reason, and I have spoken about that to them when I was an assistant U.S. attorney, are reluctant to use that law. And I think that is also part of the problem, part of the systemic problem in terms of making sure that there's personal corporate responsibility on the part of CEOs and other executives making decisions.
So, wow, this is daunting, because it's like, if they're not worried about any kind of liability and they're sufficiently insulated and they feel very cocky about it, then what power do we have as caregivers to, other than just being immensely annoying, just to get you off their back? That's it. I mean, other than that, do we have any recourse?
That's a tough question that you asked in part one of this podcast, and there's not a good answer, because the caregivers who are facing that system, you've got to fight tooth and nail. You have got to use just about all of your energy and resources just to make sure that your loved one individually gets the care that they need. That doesn't leave much space to go out there and try to change a system that is weighted heavily against any kind of change. You're talking about a system where you'd have to get Congress to act, and they're very much dependent on money from the nursing home lobby, the pharmaceutical company lobby, the physicians lobby. You have all of this money coming into them, and that again, part of the system that skews against changing it. Okay, and so I'd be very hesitant, because I know how much the folks listening to this podcast are going through personally, how much energy, how much it takes out of you to just take care of your loved one, especially if they have Alzheimer's. But then on top of that, you're trying to fight a system just to get the care that your loved one, basic care that they need. Mm-hmm. There's nothing left in the tank for those folks. I mean, I don't know how you can then say, okay, now let's take on the system that is so stacked against you.
What can you do, Rick and John? Is it the physical being present there? Is that what it is? Is that they have to see you so they know that somebody is there? Is that the best approach? Because it sounds like otherwise there's no going higher. So what you can do on a daily basis for the person that is in this facility, in this community, is to be there and show your face.
Even then, Roseanne, even then,
accountability. Well, I know, but it's a something.
It's a something.
Is that, because it sounds like, as far as the system's concerned, that's a whole nother quagmire. So then what can a caregiver do?
John, you were there.
I think, that is without question. I mean, that's the best thing a caregiver can do. I mean, that's what we've seen. I think you've seen it.
Yeah.
You've both seen it. We know that that's the case.
Yeah.
You have to be there. You have to be persistent. You have to be a problem if you want your loved one to get the care they deserve. Being there regularly, not giving up, asking questions, asking hard questions, refusing to take answers that are insufficient. Unfortunately, that is the name of the game. Beyond that, I know in Virginia, there are some resources available. There's some, here in Virginia, we have a state office of ombudsman for long-term care. That's a legal resource. They also have local offices on aging. I'm sure every state's different. This is strictly Virginia. These people, by and large, we work with them to some degree. They're good people that know the problems and really have a desire to do something about them. They're somewhat limited at times, but that's still a resource.
Mhm.
You know, you may go there, you may make a complaint, nothing may come of it. But then again, something may come of it. The departments of health in the state of Virginia Department of Health regulates the nursing homes. That's another resource. You may go there, you may make a complaint, nothing comes of it, but it possibly could. So that's another layer. Beyond that, I mean, this is all pat answers that you get. Go to your congressman, go to this, go to that. Sometimes that actually has an effect. Quite honestly, most of the time it doesn't, but sometimes it may.
Okay.
But to be brutally honest, you get back to what we've been talking about here. You're on the ground. You have to stand up for your loved one.
Mhm.
You have to stand up for your loved one on the local level. And typically, the louder you are, the more persistent you are, the more successful you will be. But that, as you know, is a great drain upon yourself as a caregiver.
It really is. It really is. It's, it's not my nature to be that way. My nature is, I have a disease to please and I want to, it's been hard to walk into a facility and say good morning and people go, literally grunt at you because you're the enemy.
Well, yeah. And it's fearful because you're only there for that period of time and then you're leaving and they are there with your person. So, you can't be adversarial because they are with your person. So there's a very fine line to try to balance.
Don't go the same time. Go a different time. That's what I do. They never know when I'm coming. I don't know. It's just something I do.
And maybe this is a crazy idea or answer to your question because it's not one that's easy and it's not one that can happen overnight. But it's the communities need to just maybe take back those facilities in their community. And I don't know how you do that, but I do know for a fact that when nursing homes were locally owned and, operated by people in the local community, there was more, not to say they were perfect. I'm sure there were issues, but there was more of a feeling of service to the patient versus service to the financial well-being of a corporation. But I don't know how you do that. It's money is what really talks these days in terms of our society.
Mm-hmm.
Everybody wants to be an investor, and everybody that invests wants to have a return on their investment. So, I don't know how many, if you own any kind of a stock portfolio, you may have stocks in nursing homes, and the nursing homes are feeding your stock portfolio. So are you going to really complain that much about it? I don't know. But to me, that seems to be, in terms of a fix, how do we, get people in the community to pull together their resources, maybe and say, we want to get this nursing home back, and we want to make sure it's taking care of our loved ones.
Right.
Because
Yeah.
we live long enough, we're all going to be there.
We're all going to be there, God willing, as my mom would say. But John, I have a question for you. Are the nursing homes not held to the same medical standard as a hospital? Because I feel like why are the hospitals seem to be, I'm not saying they're perfect either, but they seem to be more judicious about the kinds of steps that they take, and they seem to be very concerned about doing the right thing. It seems like there's much more concern about liability. Are there different standards that they have to satisfy as opposed to a nursing home?
My thinking is that, at least in the state of Virginia, the amount of oversight and the amount of regulation for nursing facilities may not lie at the same level as for a hospital. Rick may know a little more about this than I do. There is still an amount of oversight. They still are held to certain standards. Whether or not it is as closely monitored as, let's say, a hospital, I'm not really that familiar. I do not think they're held to the same standards. I do not think they're regulated by the same bodies, nor are they held to the same standard.
That's a big chasm, especially in a skilled nursing home where they're working with Foley catheters and G tubes and massive wounds on people that are, bedridden. Those things are medical services that they are providing to our loved ones, and yet the standard is different. And that doesn't seem right, Rick.
Yeah, I think the hospitals are probably on a higher standard. There are probably some state licensing standards that they have to meet. They also have, they're doing procedures that are invasive a lot more. And so there's a higher degree of liability in terms of malpractice. There's a lot of regulation of hospitals through the state agencies in terms of licensing all of the staff in a hospital. Nursing homes, on the other hand, have their regulations stem from a federal regulation under HHS, Health and Human Services, but the standards are very kind of vague. For example, as we talked about in part one, there are no minimum staffing requirements for nurses and certified nursing assistants and the like in any of those regulations.
Unbelievable.
The insurance coverage on nursing homes is substantially different from hospitals, right? Hospitals are covered by large insurers like Blue Cross, and so there's a lot more money that hospitals can earn by providing more services, whereas nursing homes, you're either self-pay or Medicaid.
Right.
And nursing homes will go through a self-pay patient's resources pretty quick and turn them into a Medicaid patient. And Medicaid's payments are limited, okay?
Right.
So there's less money to be made in a nursing home setting. The standards and regulations are a lot more vague. And, basically it's the language is sort of like to the tune of must provide care to sufficiently thrive. What does all that mean in terms of specifics? It doesn't really mean anything.
Right.
Right.
Wow.
So, and we talk about one of the ways, because understaffing seems to be the root of a lot of the problems in nursing homes. We talked about getting that the states really could solve that problem by imposing minimum staffing requirements.
Mhm.
I mean, I hear this story more and more, and it's ridiculous. One CNA is taking care of 50 patients on an overnight shift is ridiculous, but there's nothing to prevent that. Okay.
Nope.
That is not unusual. That's not contrary to regulation, but it's certainly insufficient. If you all know that just from observation. But it would be a whole different thing if there was a requirement that each of the states imposed that said, no, for 50 patients, you got to have 3 or 4, whatever the number is that experts say there should be. That would really, I think, would go a long way wouldn't solve everything completely, but would go along, be a huge step in making things better, conditions better in nursing homes. So yeah, there are two different standards. Nursing homes are not regulated as much as hospitals. Their standards aren't as high as hospitals. The root of the problem, those are understaffed. Everything goes back to that. If there's excessive pressure sores, not enough staff to turn patients adequately that aren't able to do it themselves. Not enough not enough staff to treat those wounds.
That's right.
If there's malnutrition and if there's dehydration, not enough staff to adequately feed the residents. They can't feed themselves. Not enough staff to make. That's the root, in my personal opinion. The root of most of the problems.
100%, 100%, and also the fact that they're not held to the same standard because they are providing medical services, right? And the reason why my mom is in the hospital again is because of a medical service that they weren't providing properly. And I kept saying it to them. Are you sure that should be in? My mom had a catheter. Are you sure that should be in there that long? That was from the hospital. What made it easier on them? And
Yes.
Right? So she ended up hemorrhaging because it was just in there too long. And that's frightening.
Well, right. But in a nursing home, if most of the people that live there are on Medicaid, and Medicaid doesn't pay a lot, it sounds like it's rife for the deals with the pharmaceuticals to make that extra money to make up for the Medicaid not paying as much. And it sounds like that's just the cycle. That's the wheel. Wouldn't it be? Because Medicaid only has so much, they only have so many resources for each state for the number of people on Medicaid. So it's just that continual, well, how do we get more money? Well, if the pharmaceutical company can pay us, and if we can alleviate some of the loss from the Medicaid payment or lack thereof, is that part of this system?
Absolutely. I mean, when profit motive is what drives the show, there's profit to be made on both sides of the coin. You bring in as much money as you can. That's why a lot of nursing homes push for Medicare rehab patients. They like to get Medicare rehab patients in a lot of their beds because they get more money.
Right.
So maximize the money that's coming in. Get more Medicare rehab, not as many Medicaid patients. That's for private pay, more money. So you try to maximize on that side. Bring in as much money as you can. Then you go to the other side, try to minimize all the money that goes out. Where are things that you can do that with? Well, instead of hiring 100 people per facility, you hire 50. So you cut your payroll in half. So what happened to that other 50% of payroll? It went in the bottom line. It went in the bottom line. So then you manipulate the other expense categories. You instead of buying a diaper that says a quality A, you buy a B minus. You save money.
Right.
The patient's not getting as good a diaper, but you save money.
Right. So
you've constantly got those manipulations by leadership in these things to work the money. And often, of course, the results of all this is where it's the patient, it's the resident that's not getting what they need. The resource that's finally spit out by all this is insufficient. So now local staff is trying to allocate that limited resource.
Right. But how is it done in the hospital? Like, why can my mom go into a hospital with her Medicare and Medicaid? Why does she get the better service there as opposed to in a nursing home?
The patient mix, and I've heard this term used also. Patient mix is also part of the system, right? So all of these facilities look at what patient mix should we have to maximize profits? Well, patient mix means how many private insurance patients do you have? How many Medicaid patients do you have? Mm-hmm. How many Medicare rehab patients do you have? That number, that's your patient mix.
So it offsets.
Hospitals have their normal natural patient mix, I think, is such that they have a lot more private insurance.
Gotcha.
Private insurance doesn't, unless you have long-term care insurance, your typical Blue Cross and Aetna and all those don't pay for long-term care in a nursing home.
No.
It's only
Right.
it's only Medicaid, Medicare rehab for up
Yep.
to 100 days only. After that, no coverage, and
Mhm.
self-pay. And then the few patients who manage to, buy long-term care insurance.
Which,
But eventually, all your self-pay patients are turned into Medicaid patients.
yeah. And by the way, the long-term insurance, at least in California, there's no regulation on that. People that I know that have bought it,
Mm-mm.
the rules change when they go to use it.
Mhm.
It's suddenly like, it's not for the
Mhm.
rest of your life. It's for
Or-
a certain amount of years.
No.
Yeah.
If the company's
Yeah.
still,
And
if
then
the
they'll be-
company's still available, yeah.
And then they'll become Medicaid patients. So really, the patient
Right.
mix in a nursing home is very much heavily Medicaid, which is lower reimbursement than
Right.
in a hospital where, okay, your mom's a Medicaid patient, but she's only one out of, and there's, for her, there's 25 others that have private insurance or something else. So
So
they
they're-
don't
yeah.
have to, any,
It offsets,
So
it
think about
offsets the
also
loss.
this.
It
Yeah.
offsets.
and think about
Wow.
this, what is the biggest cost in not only a nursing home, but pretty much any business these days?
Employee.
What is your biggest cost?
Healthcare.
Employee.
Healthcare.
Well, but the healthcare is part of employee benefits. So
Employee.
it's
Yeah.
your-
It's employees.
Yeah.
It's personnel,
Yeah.
right?
Right.
So to get
Absolutely.
the biggest, to maximize your profit, you want to cut costs the most, you cut people, you cut staff.
Right.
That's just, and until there's a required minimum number of staff per patient in a nursing home, they're going to be chronically understaffed.
And with COVID, there's not a part of our society that hasn't been affected by it. I mean, there was a whole story on KCRW yesterday about teachers for special ed students. There's not enough teachers anymore and so they're
Yeah.
hiring people that aren't qualified.
Yeah.
Just to have bodies. And this is what's happening in nursing homes. They're training as they go, which I saw that, I witnessed that, and I understand it, but there needs to be some transparency to us so that we know as caregivers and residents what we're up against. So just give us a fair, because I think one of the things that you said that was very profound in our pre-interview was that it doesn't matter how much you spend on your care and what the advertising says and how beautiful the brochure is and the rating system on it, because they're all the same. I'm sorry to have such a depressing conversation, you guys, but let's get real, because, I want to live a long time. I don't want to end up like that. And I don't think you do. Sometimes I say it's a blessing my mom has Alzheimer's, because she doesn't really realize what a burden she seems to be to most people. You know what I mean? And that's sad to me. That hurts my feelings. And I'm glad that she doesn't know that.
Well, it's also one of those things where people don't realize until they're in it, and then they get in it and they're like, wait a minute, what is this? Is this how it is? And it's like, yeah, that's how it is. And that, I don't know how it needs to be more prevalent. We need to talk about it more so people understand that this is the path. You can't keep up with these costs. There's no way you can save enough money to pay for your care as you age. There's just, you're going to run through it, and everybody winds up on Medicaid. And I don't think people realize that everybody winds up on Medicaid eventually, because you've run through
If
your
you
money.
live long enough,
There
yeah.
might be a small percentage of gazillionaires that don't, but for the rest of us, eventually that's what happens. And there has to be some sort of a better setup for that. I'm sorry, Rick, I started to speak and I cut you off, I believe.
No, that's, no, I think you're right. And again, to me, we're not going to change the system because it's been in place for so long.
Right.
Congress is beholden to monies from nursing home owners, and other people in the healthcare industry, from pharmaceutical companies. and they're not going to pass any kind of legislation that limits themselves from receiving that money. And then, but the one thing that would make things better, not perfect, but better, is to somehow get the states the state legislatures to impose minimum staffing requirements. So, and the problem is this, that I've had conversations with people about their loved one in a nursing home many times, and they talk about how, well, they're not, people don't come and check on them on a timely basis. They're not taken to the bathroom. They're not changed when they get wet and all that kind of stuff on a timely basis. And unfortunately, I've gotten to the point where I say, you know what? Unfortunately, that is just the way it is in every nursing home in the country because they're understaffed. And I hate that I have that's my view. But unfortunately, I think it's the reality. And how do you fix that so that you're not going to make things go from being bad to now, hey, they're great, but
Right.
you could make it
No.
going from being bad to being better if they had enough staff there to,
Right.
get people up and feed them that need help, and turn them so they don't get pressure sores, and change them in a timely way if they soil themselves and all that. If they had enough people to do that in a timely basis, and it wouldn't take a lot, but unfortunately, it would cut into corporate profits. So sorry to do that, but it certainly would improve their care.
Right. But
Huge
what could we do
Right.
what would incentivize them to do that then? Because they're, like you said, it's bottom line. So what would be the incentive to do that other than some kind of standard that they have to be held to, and and the repercussions of not being held to that standard? It seems like other than that, we're just saying, be good guys. And, where do we get our leverage from? I know you're saying the system is tight and it's really locked up, but what part of the system isn't? Is there any hole in that system that I can fit through? I'm tiny. I'm not, I'll go through it.
You've got to get to your state legislators, the ones who pass the laws for the state, and somehow convince them that you don't have to be addicted to the money from the nursing home lobby. You need to do something that's going to help our loved ones improve their lives, and pass legislation that says nursing homes have to have a minimum staffing requirement. That's the only thing I can think of, John. I don't know if you have.
No, I think that's in a nutshell. And I hope I'm not speaking without a sufficient basis here, but I believe I have seen in the news that possibly there has been some talk by the Biden administration about the need for staffing standards in nursing facilities. I don't think I'm wrong there. And I hesitate to even mention that because I don't really know any of the details.
Okay.
But I do seem to remember that I have seen something along those lines in the media. So the fact that government at some level is talking about this, to me, is some grounds for hope, because that's how it starts. You have to talk about it. You have to acknowledge a need. And I think everybody in the industry knows this is the problem. And I think in America, our society, I won't say we got blindsided by this problem, but we should have seen it coming and we didn't.
Yep.
But over the last several decades, we all know our elderly population has grown fairly substantially.
Yes.
So we as a society didn't see this, maybe didn't acknowledge this, that, hey, people are living longer.
Yep.
We're getting more elderly people with the problems that go along with that. So all of a sudden now we have the demand on a system that probably wasn't up to handling it, would have been a problem in and of itself. And then we throw in the fact that, hey, guess what? This is a great area to make a lot of money. Okay. The money that comes in is good. It's mostly coming from the government. So the money's pretty secure coming in, and we can play around with what we're spending going out, so we can make a lot of money here. So throw those two factors together,
Right.
and I think that's given rise to where we are today. And unfortunately, who's trying to bear the brunt of dealing with that? It gets down to the people like you two on the ground, trying to make sure your loved ones are getting some level of care. But getting government to at least acknowledge and talk about this, I think, is a beginning. Like Rick says, you know, it's obviously an uphill battle getting actual legislature, but hey, before Obamacare, there was no national health insurance.
Oh, yeah. No.
Right.
Yes.
So,
So it's got to start
Say-
somewhere. Yeah.
exactly, you got to start somewhere.
Yeah. It's a whisper to a conversation, to a yelling, to a let's fix this.
Look, I
Yes.
think there's nothing better, more important for me to do, as I'm a filmmaker, but you know, this will become a film. It has to. And because I'm seeing too much, and it's deep. I mean, it's like you said, you know, and on a human level, it becomes a journey that is, I mean, so massive that I'm obsessed with it right now, because I feel like possibly have enough energy to do it. I don't know. I'll see. I feel, you know, I feel like I was blessed with a lot of energy, so I should make the best of it and see what I can do with that. And also I'm extremely emotional. So, you know, I'm on both sides. I feel like, you know, maybe I have good tools to do, at least make some noise and bang the drum and pots and pans, at least get some, you know, some ears and eyes on a situation that is probably the worst crisis we could have right now, because it's a financial crisis. It's an emotional crisis, and it's got to be a universal crisis. We can't be the only country like this. I mean, this has got, you know, we have just marginalized. I know ours is the worst. I'll put myself on the line and say that, but we have marginalized the hell out of aging, and see it as a, you know, a liability and an embarrassment, as opposed to
Part of life.
and a celebration. So that's just crappy. That's just crappy. And I mean, it's just the worst. So, anywhere in that system, I guess our best bet, as you said, I'm going to repeat, is legislation, and to continue to, because I know people have tried, and I know they get turned down. Wasn't there a big report that just came out, a 600-page report, Roseanne? That was like,
Mhm. To a revamping of the nursing home system, and the last time it was revamped was in 1987, which is insane, or 83. It's
Yeah.
insane. Yeah,
and it was dismissed.
it's got to make it through its system. It's got to make it up the chain, and I mean, we've heard why the resistance is there, and it makes perfect sense when you lay it out like that. It makes perfect sense, and then it's just a matter of how we go forward with this.
All right, back to the happy news. So, John,
Back to you,
back to
Susie.
me. So back to happy news, John. What's the most egregious thing you found when you were boots on the ground? I'll tell you mine, and you tell me yours.
I would say, you know, in the Abbott case, and there was obviously many facets to that investigation, to that case. There was a lot of elements involved all across the healthcare industry, pharmaceuticals, medical. I think what concerned me the most that I saw in that case was, you know, the pharmaceutical companies, they operate pretty simply. They're in business to make money. They're in business to develop products and sell them and make money. Okay, that's why they operate the way they do. But I guess what would concern me the most is the elements in the medical community. And I'm talking about researchers, I'm talking about medical doctors, practitioners that seem to be more than willing to maybe not carry out their standards in what they did and how they interpreted things and how they did their activities. Because to me, people in the medical community, they take an oath that they're held to a higher standard.
That's right.
So, you know, to say the most egregious thing I saw in that particular case, that was an area of concern for me, because I know, at least in my parents' generation, you know, if you were a doctor, what you said was gospel.
Right?
They never challenged anything. Having the medical affiliation, it's like and of course, I don't think most of us nowadays are at that point, but I know at least at one point in America, Americans were.
Yeah.
So that's a lot of power. That's a lot of power right there, just because someone has a medical degree or whatever after their name. So to me, to see somebody in that position, then take that position and turn it around and distort it somewhat for their own gain, that was bothersome to me.
I agree with you. I've seen that. I saw that personally recently, and you know, so much for the Hippocratic Oath, and you know, and I think, again, going back to what you said, Rick, that even the doctors are understaffed. You know, so they're doing the minimal amount because they don't feel I'm sure, like one of the doctors I know that's, you know, is older and I think tired, and you know, and us up against the system too. So it's easier to just go with the flow and not, you know, not fight for their patients because they're just tired. And I get it. I'm not, you know, I can't even, I only think we can blame what's, like, you know, the fish smells at the head. Is that the saying? I mean, I think that's the other one I won't say because it's ugly. But you know, I do think that everybody is in the process is a victim of whoever's above them, and then the lack of regulation that protects them as well as us. Right? Does that make sense?
Well, it sounds like the Abbott case and the Purdue case ran the same course, in that we're going to say that this provides this to patients when really it was over here. And then it just kind of ran. Is that pretty accurate, that Abbott kind of followed Purdue's playbook? Purdue with Oxycontin and Abbott with Depakote, I should say.
It's accurate in a general sense. In the Purdue case, it was basically just lying about the drugs, the dangers of OxyContin, basically lying and saying that OxyContin was less addictive and less prone to being abused than other opioids, than the competitor opioids. Similarly, what Abbott did was they maybe even took it a step further. They took a drug that was approved for one set of uses, you know, epilepsy, bipolar mania, prophylaxis for migraine headaches, and market it for something that was completely outside of those uses. That is treatment of agitation and aggression in elderly dementia patients, primarily in nursing homes. And the FDA had made it clear to them that they would not sign on to any kind of approval for that use, even if they did studies that were successful. Okay. So in some respects, they went completely outside the lane to promote that drug, whereas Purdue, they took a drug that was a pain drug, promoted it for pain, but lied completely about whether it was addictive or abusable or not. And the result, of course, was much more clear and much more devastating, because now we have the opioid crisis as a result of that, and 100,000 people a year are dying of opioid overdoses. But Abbott, in similar fashion, and many other forms, you know, if you go and look at the Department of Justice's website at their press releases over the years, beginning back into the mid to late 1990s up to the present, there have been dozens of settlements with pharmaceutical companies for the unlawful and improper marketing of their particular drug. dozens upon dozens, and some companies have had it done to, they've been caught multiple times, always resulting in a large monetary fine and restitution and all that. But and rarely have they involved holding a corporate decision maker, an individual responsible.
Right.
So it's the cost of doing business, basically. And Abbott did, they went about it in a very blatant and I think arrogant way. They set up a whole division within the company that was devoted to marketing it for an unapproved use. I mean, part of their organizational structure included a box for this long-term care division to promote the drug for something that was blatantly not approved in that realm.
Oh my gosh.
That was pretty arrogant.
Yeah.
And then they used these clinical studies, which John can speak to probably in more detail because he kind of focused in on that. They took clinical studies that basically failed, that said that, Depakote doesn't really do anything more than, placebo. It doesn't really address that, and cherry-picked language out of that to use those to promote the drug to doctors. And what they were doing was trying to evade the OBRA 87 regulations of antipsychotics. And they were saying that those regulations don't apply to us. If you have agitation or aggression in elderly dementia patients, nursing homes, and doctors prescribing it from nursing homes, if you prescribe Depakote, then you don't have to worry about this strict scrutiny you would get if you prescribed an antipsychotic. So, John, I don't know if you want to add to that.
Yeah, the whole thing with the clinical studies, as Rick said, there was no approved use for this drug for agitation and dementia. So they were looking at a situation where this had been one of their flagship drugs, and they were about to lose their patent protection. This drug had been out there a long time. So you've got a limited amount of time left before you lose patent. So their theory was that, hey, based on research, we think that this drug actually is therapeutic to the underlying disease here. Okay, the Depakote actually treats the ailment in the brain that causes dementia. So that was their theory.
Oh my goodness.
You want a clinical trial that is going to show that. So they geared up to do this trial. Now, keep in mind, Rick mentioned that they set up a whole sales division. So they had already set up this sales division. This salespeople are already going out there marketing this drug, to treat dementia patients with agitation. At the same time, now they're saying, we're going to do this study to show that this works. So they gear it up, and they started out, and it did very poorly. They shut it down pretty soon after they started it. They started to revive it at a later time, but they never did. So they had no clinical studies to take to the FDA to show that this drug is actually therapeutic, therefore it needs to be approved for this use. All during this time period, they had salespeople out there marketing this drug to treat this condition. So the clinical trials was going to be that pass to let them get out there and do this, but they were doing it when they didn't even have a clinical
Anyway.
trial. And their theory just never held up. This drug was not therapeutic to the underlying condition.
No.
So as Rick said, that's kind of a blatant operation when you don't even have the trial. You're trying to set up a trial to cover what you're already doing.
Because they can be arrogant because of that system. They feel insulated, like you said. So there's this arrogance that could bleed over not just in our senior, community, but into all communities that use medication. And we really are at the mercy of, I mean, I don't even know how do you trust anything? Like, I remember a friend of mine who's a nurse said, oh, metformin is really good for losing weight, which is like a diabetic drug. And she's like, all my friends are on it. Do you want some? It's like, no, I don't want that. No, thank you.
So there's the drug. How do you find out like legitimate information about the drugs? Is it drugs.com? Are they shaded? Like, how do you find this out so that if a doctor says, okay, we're going to try this drug. I mean, I go to drugs.com. I go to the NIH. I look everything up. But then is that what you should do? Because in my mind, I think, well, if somebody comes to the doctor and says, I have this pill and it will treat this, doesn't the doctor look at that? Or do they just go by what's on that paper? Like, here we have these clinical trials that we're lying to you about, but it says it does this. Like, how do you maneuver through all of that?
Well, to answer your question, as ludicrous as it may sound, doctors do listen to the non-medically trained pharmaceutical rep that walks through their door, as they did in the case of Purdue and OxyContin, much to my shock, that physicians who've been to medical school for 4 years plus, on top of their college education, done a residency for I don't know how many years, 2 to 4 years after that, somebody just out of college walks into their door with their history degree or whatever, nothing wrong with history degrees, or let's say my degree, business economics. They walk through the door and say, let me just tell you all about this drug. And they give them a marketing pitch, and the doctors, they go along with it. I guess it's easier. Again, path of least resistance.
Right.
Is it easier for a doctor to spend 2 hours of their free time researching and reading?
How? They can't.
It's impossible.
I remember when my brother was on OxyContin, I literally called his doctor and said, why are you prescribing my brother 900 milligrams of OxyContin a day?
What?
He goes, do you know that your brother had a laminectomy and a back surgery? I go, yeah, I do, because I had the same surgery. I had a laminectomy. I had a ruptured disc. I go, I know how bad it feels. And I said, nobody needs to be on that much OxyContin or pain medicine. I didn't even know what OxyContin was. I just knew it was pain medicine. I was like, why are you prescribing so much to him? And he said, everybody's pain level is different. The end. That's what he told me. And
that was the Purdue marketing spiel. That he was parroting to you what the marketing discussion was that came out of Purdue.
Yep. Yeah. It was horrible. So let's recap. You guys are great. I love you to bits.
You guys are great.
Know your enemy. I'm quoting you, John. Know your enemy. If you can, go be there, be present. If you can't be present, there's records. You can ask for them. You can ask for what your loved one's on. Ask them to give you a list of the drugs that they're on, and do your research. Go, whatever you can do, go to drugs.com, go to the NIH, go to the CDC. It's on us. We have to protect ourselves, and we have to be vocal. So did I miss anything else?
I'll say one thing. I would say, add to that list, it's okay to be a mean person when you're advocating for your loved one, especially in the nursing home system. And that's because you're fighting a system. You're not fighting those individuals.
Beautiful.
Keep that in mind.
Beautifully said. That is good to know. And I'm going to remind myself all the time, because I've literally walked in and said, I don't want to be this person. Please stop making me be this person. And I just the other night, one of the nurses walked out and the other nurse stayed behind, and she said, if that was my mom, I'd do the same thing. You're doing a good thing. And I broke into tears, because I was like, can I hug you? Thank you. Wow. I mean, if these two people this is what they do did for a living, it's like, and say how hard it is. Can you only imagine for us? So But of course, there's power in numbers, and it's got to start somewhere. So it needs to start.
Yeah.
So if you have stories, let's tell the stories. They're really powerful. I know that as a filmmaker,
Yes.
doing the film on my mom has really resonated, and it makes a difference if you can tell a personal story. DOPESICK that Hulu put on was a brave story to tell, and it was important. If you haven't seen it, watch it. It's hard to watch. Roseanne was like she's like, I can't watch anymore. I'm so frustrated. I'm so frustrated.
Oh my goodness.
And I said,
Rick, I don't know, man. I don't know how you did it, Rick. I don't know how you did it.
Yeah, I think as I look back, part of how I was able to do that or be in that case and push through that case was because, and it was from a really small office, was because of people like, in both the Abbott case as well, because of people like John and Harold. And being in a small office was an advantage because, John and I have worked together for over 30 years. Harold and I had worked together for even longer than that. And so by the time we got into these cases, we know each other. We had a personal, relationship with each other. And you can do a lot more when you are working with people like that you have a relationship with, that all are pulling towards the same goal, that have no personal agendas, no monetary agendas, other than trying to do the right thing.
right.
So,
Yes.
so that is, I couldn't have done that by myself in a normal environment without people like John and Harold, being able to work with them and see them on a day-to-day basis and know that we were all about just doing the right thing and not having all these other agendas out there, and being able to withstand the opposition that was presented in those cases. You got to have a group of people that help you do that.
You really do. You got to find like-minded people in any situation that you're trying to get something done, and you have to find your tribe.
Thank you. And thank you. And
Yeah.
thank you for all of the work that you've done, that both of you have done.
And
Thank
Harold.
you,
And
because-
Harold.
And Harold, because it made a difference, and
It made a
you're
huge
honest
difference.
and honorable men that have integrity and are not afraid to stand up. And I thank you, at whatever personal cost it may have cost you, away from your families and away from anything else that you wanted to do in your life. But it was important, and it's thank you.
Yeah.
Just
And
thank you.
thank you for being just such amazing men anyway. Like Rick knows I love you. And you've been so helpful with me just on a personal level, just supporting what I'm going through. And John, I just thank you so much too. You're a delight. And everybody just keep on trying. Don't give up. We are strong together. And follow Roseanne everywhere on heyro.com and on her wonderful podcast, Daughterhood, the podcast. And also thank you for listening or watching us on Love Conquers Alz, and share our shows with other people that you think might need this information, and especially this episode. And you know why, you guys? Because
you'll just keep going.
Yeah, I'm just going to keep going. Because, as a matter of fact, here's why. Because love is powerful, love is contagious, and love conquers all. And it really does. Yeah.